The word prostate cancer has become so common that nowadays people are not much worried about the diagnosis of the prostate cancer. In good old days, many patients used to present with metastatic disease. The patient would be older, he would present with low hemoglobin, that is anemia, back pain, urinary symptoms, loss of weight and appetite, and that used to be pathognomic of metastatic prostate cancer, meaning the prostate cancer would have spread to the bones, and the survival in these patients used to be in the range of about 2 to 3 years. Gone are these days. Thanks to the technology, thanks to the PSA, thanks to the awareness and probably screening program across the world, now we are getting this prostate cancer picked up in a much early stage. Now, what are the symptoms of the prostate cancer? To be very frank, you may not get any symptoms at the age of 50 or 60 when you go for checking up to find out whether you have prostate cancer or not. Who should get screened? The patients who are at high risk of developing prostate cancer, meaning if one of your family member has suffered from prostate cancer at a young age, like your father, your brother, then perhaps I think you should talk to your doctor and get the test called as PSA test and get yourself examined to find out whether you have prostate cancer or not. Maybe some of the patients would have symptoms exactly like what you get for a benign prostatic enlargement, like a weakening of the stream, incomplete bladder emptying, and sense of incomplete feeling of the completeness of the micturition, nocturia, and so many other lower urinary tract symptoms. Now, go and see your doctor to get yourself checked for the prostate cancer. The doctor would do a test which is called as a PSA test, as I mentioned already. But what is important is not this biochemical test, but have a thorough examination by your doctor. As a urological oncologist, what we do is we examine their abdomen, we do a rectal examination to find out the feel of the prostate, and many times you get a feel that this probably is not a normal feel or a benign feel, or a patient may have a suspicion of a prostate cancer. Now, if the PSA test shows it's more than 2.5 or 3, or there is an abnormal feel of the prostate, we subject the patients to do a transrectal ultrasound scan. Nowadays, rather than transrectal ultrasound scan, we are doing a test called as a MP-MRI or a multiparametric MRI. Now, this would tell you about the architecture of the prostate. This would also tell you about the location of the tumor, if at all there. It would tell you whether there is involvement of the seminal vesicles or adjacent structure. If the multiparametric MRI tells you that there is suspicion of the cancer, now many times we fuse the images of transrectal ultrasound scan and MRI, marry them together, and then do the biopsy of the prostate. There are many ways of doing this biopsy. Minimum 12 to 16 cores or 24 cores from both the lobes of the prostate are taken, and they are sent for the histology. Now, once the pathologist tells you there is an element of cancer in the prostate, we measure this extent of the cancer by a scoring called as a Gleason scoring. Nowadays, there is a modified Gleason scoring system which is called as ISUP grade group system, which tells you the severity of the cancer. The next step what we do in these patients is to stage the disease by doing a bone scan, because these cancers have a propensity to go to the bones. Now, depending on the stage of the prostate cancer, the treatment can be tailored. If it is a stage 1, meaning the tumor is of a less volume, is limited within the prostate, then we have a choice of either doing an active surveillance, meaning watching these patients very, very carefully and treating them only when the disease progresses. It is just not a wait and watch that many people think about. The commonest operation, if at all is to be offered, is radical prostatectomy. Thanks to the understanding of the anatomy of the pelvis, the nerves, we can now do a very precise operation to remove the prostate along with its capsules and seminal vesicles and join the bladder back to the urethra. The continence can be almost same as before the operation, and in fact, if you can do the nerve sparing operation, your sexual function can be also preserved, and that is about radical prostatectomy. If the patient is not keen for radical prostatectomy, these patients can be offered radical radiotherapy. But remember, this treatment is to be carried on for almost 6 to 8 weeks time, and you always have to watch them very carefully for development of cancer at a later stage. Now, if you have a stage 2 disease, meaning the disease is within the prostate, it is not any more microscopic, it's probably sort of picked up into the prostate on imaging, but it is not gone beyond the confines of the prostate. So if it is stage 2, we can offer these patients radical prostatectomy or radical radiotherapy. Now, if it is stage 3, meaning it is gone beyond the confines of the prostate, if it is infiltrating the seminal vesicles, if it is involving the nearby structures, then there is a big question, the curative nature of radical prostatectomy in these kind of high-risk patients. In these patients, it may be appropriate to treat these patients with radical radiotherapy, and before radical radiotherapy, these patients can be augmented with hormonal therapy for 3 months, radical radiotherapy, and followed by about 3 to 6 months of hormonal therapy. What about stage 4? What do you mean by stage 4? In these patients, the disease is palpable on rectal examination. The PSA is usually in the range of hundreds, and they have metastasis to the lymph nodes and the bone, which is the commonest scenario. If that is the case, there is no role of radical surgery. Only in these patients the hormonal therapy can be given. Now, some patients with a metastatic prostate cancer have a good quality of life for 3 to 4 years. Unfortunately, they keep on relapsing, the PSA starts rising, but thanks to again research in the basic sciences, now we are getting more and more patients to be treated with second line of hormonal treatment, the chemotherapy, and lots of new exciting drugs which have come for metastatic prostate cancer. So the bottom line, every man has a risk of developing prostate cancer. The risk increases as per the age. It is better to get checked with your doctor, find out the stage of the disease, and then only make a decision about treating the patients. One last word, those people who do not make distinction between benign prostatic enlargement and prostatic cancer before treating the prostate problem or the prostate trouble, I think they are making a huge mistake, because it's no point in finding a diagnosis of prostate cancer after doing an operation which for so-called BPH and then repenting. So beware, get your PSA done, see a proper doctor, and make sure you are dealing with a BPH or prostate cancer before embarking on a treatment of your great prostate problem.